Hi guys, thanks all for coming. We hope you're excited for today's webinar, which is on trauma and orthopaedic surgery. As always, if you have any questions, please put them in the Q&A box rather than the chat function as we monitor the Q&A. And also just to let you know, all of your videos and mics are automatically turned off, so don't worry about that. Today, our lecturer is James, who is a senior orthopaedic registrar in the Severn Deanery. He believes it is vital to enthuse medical students and junior doctors about orthopaedics early on in their careers. He has won awards for his innovative approach at enhancing the learning experience of medical students on their orthopaedic firm at Imperial College. James has organised or been faculty on a number of national and international courses and seminars on the topic of orthopaedics. He has also spent 2 years on the British Orthopaedic Training Committee, and most importantly, as a staunch feminist, believes a career in orthopaedics is not just for men. So without further ado, I'll pass over to James.
Thanks very much. Thanks very much for inviting me to come and talk. It's an absolute honour. I guess the first thing I will just say is that I'm hoping that I'm not going to be teaching any of you guys how to suck eggs, and if anything's a bit too basic, please let the sort of committee know, and I'll sort of just move on. If we just move on to the next slide, we've had some IT issues, so someone else is managing the slides for me.
1 second. Oh, there we go.
So I kind of took inspiration from the urology presentation for this particular slide, and basically orthopaedics kind of crops up absolutely everywhere. Personally, I came to orthopaedics very late in kind of my career, as you could say. I actually didn't even think about doing orthopaedics until I was an F2, and I felt like orthopaedics was really badly taught at my medical school, at least. But it is something that crops up absolutely everywhere. So whether you're kind of a budding orthopaedic surgeon or not, you really kind of, it's really important to have a good basis in it. So, you know, it turns up in O&G. My wife recently, we just had our first baby, and she had back pain and symphyseal pain and all sorts throughout her pregnancy. Also important in terms of neonatal screening. It's important if you're a GP for all of the reasons. It's an incredibly common reason for patients presenting. It turns up in pediatrics and peds A&E, all sorts of syndromes, but also septic arthritis, which we're going to talk a little bit about a bit later in this talk. Anaesthetics ITU, whether you're looking after post-op cases or major trauma patients. It turns up everywhere. Oncology, medicine, bony mets, diabetic feet, inflammatory arthropathies, you name it. And then, of course, whether you're going to be a radiologist or a pathologist, you need to know all about it. So I'm hoping there's going to be something for everyone, and that you'll enjoy the talk and get something from it. Next slide, please. So we're going to talk a little bit about sort of how to get on your first day of your TNO firm if you have an orthopaedic firm in your foundation training. Basic of orthopaedic assessment, hopefully, which would cover finals and FY jobs. What I call the 9 nasties, and of course, this is not a sort of an all-encompassing list. There are lots of nasties around when it comes to orthopaedic emergencies, but these are kind of the 9 big ones that I always kind of watch out for and ask my SHOs when they're on call if they're happy with dealing or at least recognising some of these things. Hip fracture care, incredibly important, and whether you're on a orthopaedic firm or an orthogeriatric firm or A&E, you need to know about it. And this will encompass a little bit of post-operative orthopaedic care as well. So we'll cover a bit of that, and then just throughout the talk, hopefully highlight some pitfalls along the way. So next slide, please. So hopefully this is not going to be you on day 1 of orthopaedics, and certainly the reason for this talk is not to kind of talk about the technical aspects of it. This is really just how to take care of yourself on the wards, but also in A&E as well. Next slide. I think that the orthopaedic SHOs nowadays, I think many of the consultants have really forgotten what it's like to be an SHO, and I think being an orthopaedic SHO or a surgical SHO these days is really incredibly difficult. The main reason for that is that the firm structure's basically disappeared. And so because there's no real firm structure, it's often difficult to know what you should be doing at any one point. But I really want to kind of emphasize that the job of the FY1 and 2 on an orthopaedic firm is absolutely vital. You are a really important cog in the kind of machinery of the firm, and the reason for that is basically everything you do is going to affect whether that patient can safely get to theatre for the next day's list, the next day's trauma list. And so while sometimes you might get a little bit disillusioned and you're not really sure, there's often a big disconnect between what happens in theatre and what happens on the wards. I really want to emphasise that you are incredibly important, and trying to get this stuff right is really important. So we're going to talk about a lot of the stuff on the right hand side of the page. And I just want to say also, if at any point you're not sure, always ask for help. And that just goes for any job, I guess. Go on, next slide then, please. So basics of orthopaedic assessment. So I hope that that this structure will serve you not just for orthopaedics, but for finals and for any firm that you're on ever. People like doctors that have a good structure when it comes to an approach and the way that they approach care. The way that I do it, if someone's kind of quizzing me, like, what do I want to do with this patient? Well, I'm going to do some bedside, laboratory and special tests. And if you say that for anything, in any aspect of medicine, you're already on to a winner, because the consultant that's standing in front of you knows that you have a structure and knows that you have a well-ordered sort of way of thinking things through. So when it comes to bedside things, where you're going to take a history. Now, when it comes to orthopaedics, it's really quite straightforward. Pain history will get you pretty far, because most of the time patients will come to you with pain. And so your Socrates history is really important. So site, onset, character, radiation, alleviating factors, exacerbating factors, time, severity, all the rest of it. So just taking a basic Socrates history is you're definitely onto a winner. And usually the 90% of cases, or 90% of the time, you'll get the diagnosis just from the history alone, and everything else is just confirming what you already think is going on. When it comes to examining, again, at the bedside, it's really straightforward. Just look, feel, move. So they're going to be pointing to the joint or area on their body that hurts. You're going to be looking at it. Does it look red? Does it look swollen? Does it look deformed in some way? What's going on around the skin? Is there a big lump? All the rest of it. Have a look and see how they're walking. So if they're walking in from the waiting room in A&E, are they able to bear weight through their leg? If not, that's often quite a worrying sign. And you're going to feel that area as well, and you're going to feel the area exactly. Try and pinpoint exactly where it's painful. And then you're going to feel for temperature changes. Again, try and confirm whether there's an effusion or not. And then you're going to also assess the neurovascular status of the limb, and then think about moving it if that's comfortable for them. If it's not comfortable, don't kind of push them. You can always say, I don't mean to cause you any pain. Would it be okay if I tried to move the joint? And then when it comes to movement, you want to try and get them to move it actively first to see if they're able to move it, and then also see passively how far you can move it. And sometimes you'll find there is a difference between the active and the passive range of movement, and that can be quite telling as well. Other bedside tests include just basic observations, doing an ECG. So when it comes to kind of your pre-op investigations, that's important. Bladder scans we'll talk about a bit later, but that really comes into its own when talking about Cauda equina syndrome, which we are going to touch on. Doing urine dipstick, so often quite commonly hip fracture patients will have urine tract infections, so it's important to know that beforehand. And also diabetic patients, so blood sugars. What I'm trying to emphasize here is that I'm not just putting all these words in, history, examination, obs, etc., just to kind of tick boxes. There's a reason why I've said each of those things, and when it comes across in finals, it's important to at least have one reason why you want to do an investigation. Similarly with laboratory tests, so preoperatively in the context of trauma, or even elective setting with joint replacement surgery like a hip or knee replacement, it's important to get a full blood count to get an idea of whether they're anemic or not, what their platelet count is like, so that are they going to clot well. We're trying to think about things that trying to avoid problems either during or after surgery. So it's about thinking about that sort of thing. White cell count, have they come in with a septic arthritis? Do they have an infection? Usually it's important to know their renal function for all the reasons. Clotting, of course, if you're going to take them to surgery, you need to know their clotting status. And it's important to get to understand whether you get either just a group and save, or whether you're actually going to cross match them for blood. In the context of trauma, major trauma, or the unwell patient, an ABG is obviously essential, and in the context of infection, blood cultures. Special tests, so x-rays, we all love x-rays as orthopaedic surgeons. Ultrasound scans can give you a bit of information about soft tissue issues, but also infection, particularly in the context of children with infection. MRI scans as well are important for soft tissue problems, also infection, osteomyelitis, that sort of thing, similarly bone scans. And then joint aspirations. I'm going to talk to you a little bit about joint aspirations in the context of septic arthritis and periprosthetic or prosthetic joint infections. It's a really important pitfall that often you'll get wrong once as an SHO or an FY1, and you'll never do it again. And we'll kind of touch on that a bit later. Next slide, please. So when preparing a patient for theatre, it's just important to have a think about why is the patient being admitted. So you may not have made the decision to admit the patient. Maybe the decision's been made by your registrar, maybe the decision's been made by one of your senior SHOs or even the consultant, but it's important to talk to them and figure out why they've been admitted. Have they been admitted for surgery tomorrow? Have they been admitted because they have an infection which they're being investigated for? That makes a difference in terms of, are they going to need to be nil by mouth overnight? What sort of pre-op investigations are going to be needed? Are they going to need fluid resuscitation, in which case they're going to need IV access? Have a think about the drugs that they're on. So are they on anticoagulation? If so, does that need to be reversed? Lots of the DOACs and NOACs can be problematic, similarly with warfarin as well. So these are all really important things to think of. And then the questions to be asking your registrar or SHO are, should the patient be marked and consented? Is it your job to add them to the operating list? Different trusts differ, and so it's always important just to clarify your responsibilities before starting that job, to see what exactly you're being asked to do. Generally speaking, you won't be asked to mark or consent a patient if you don't know how to do the operation. So if you ever ask and you feel uncomfortable, you should always just say so, and probably just a registrar being lazy, and you should tell them to kind of do their job in the nicest possible way. In the context of trauma, have a think about neurovascular observations, have a think about compartment syndrome, which we're going to talk about a bit later. Does the patient's leg or arm need to be elevated? Do they need traction? It may well be that you're not overly familiar with some of these terms or even some of the indications, and I can't cover everything in this kind of 1 hour talk, but it's always good to be thinking about them and ask those questions to your seniors, because it will then show them that you're sort of thinking about the patient you have in front of you, and that you're not just kind of trying to float along and not kind of be involved in the patient's care. Yeah, next slide, please. And as I said, and I won't dwell this point too much, but really, if ever you're feeling out of your depth or you're not sure, then just ask for help. I mean, that really is kind of your job as a first aid doctor, and as a foundation trainee, as a core surgical trainee, and all the way through the ranks, even up to consultants. Consultants ask each other for help all the time, and so don't be too proud. If you're not sure, just ask someone, and you'll always get information from someone. Next slide, please. So these are the 9 nasties I was kind of alluding to earlier. And like I said, this is not an extensive, all-encompassing list of every orthopaedic problem, far from it. But these are just some of the big sort of titles that, I tend to kind of, I actually tend to do a little kind of like mini quiz for the SHOs before they start the shift, particularly if it's their first week or so on the job. and they're often quite anxious about coming across some of these things, and we just kind of go through them. So I'm going to kind of go through them with you as I would with them, but maybe just take a bit more time over it. So we're going to talk about open fractures, neurovascular injuries, compartment syndrome, septic arthritis, neck fash, flexor tendon sheath infections, Cauda equina syndrome, nasty fracture dislocations, and supracondylar fractures of the humerus in children. Now, it may well be that some of you have heard of these problems. Some of you may have never heard of these problems and think, gosh, is this going to come up in finals? I don't think all of these things will come up in finals. Maybe things like compartment syndrome might, Cauda equina syndrome may well do, but maybe some of the others won't. But certainly if you're on an orthopaedic firm, you should know about these problems. If you're in A&E, you should definitely know about these problems. And if you're on a PEDS job, when it comes to septic arthritis and supracondylar fractures, you should definitely know about it. So all things to be thinking about. Next slide. So open fractures, very simply, it's a soft tissue injury with an underlying fracture. If you just go to the next slide for me, it's a bit graphic, I'm afraid. But so there's a spectrum of open fractures from the far left all the way to the very right. But actually, even the injury on the far left is still a really serious soft tissue injury. And often the tissue can be just as damaged as the picture far on the right. This is a problem. And the first thing you need to think about whenever you get faced with this, and obviously you're not going to be the only one dealing with it. You know, you're going to be part of a trauma team. You're going to have a registrar there with you. It's a multidisciplinary thing. So you're never going to see this on your own. But obviously it can be quite a daunting thing to sort of come across. So if you go to the next slide. So here's just basics of how to deal with these if ever you come across them. The first thing to think about is take a look around you and figure out where you are. Because if you are not in a major trauma centre, then these injuries should not be treated there. And actually the pathway, the national kind of agreed pathway, is that these patients should be essentially dealt with in a major trauma centre. So I have definitely been on call when an ambulance crew hasn't quite got it right, and they thought, well, this hospital, this like regular trauma unit is nearby, so we'll just drop the patient off there. That's actually wrong, and you basically have to say, you know, I'm sorry, I shouldn't even really be seeing this patient. They should just be going straight to major trauma centre. They should be going back into the ambulance and straight over to the major trauma centre. There are some caveats. If the patient is, you know, hemodynamically unstable and they're unlikely to make the transfer alive, then they should obviously be stabilised in the unit they're taken to. But that will obviously be a decision that's taken by the A&E consultant and sort of slightly higher up the chain. So the important things to think about always is primary survey. So even though they might come in with a horrible looking open fracture of the leg, you always never kind of dive straight into that unless they're kind of you know, have this overt sort of catastrophic bleeding. You basically always start off with the airway first, and then to breathing, then to circulation, then to kind of your disability, so everything else in terms of secondary survey, and fully exposing the patient. And while that's happening, you know, trauma team would be dealing and assessing with them to rule out other life or limb-threatening injuries, and think about antibiotics. So one of the big things that makes the biggest difference really is not just being in a major trauma centre, but also having antibiotics in a timely fashion. It's always going to be IV, so make sure the patient has good IV access. And often as an SHO or an F1 on a trauma team in a major trauma centre, and some of you may find yourselves there, you know, your thing will be getting IV access and getting some bloods, including a blood gas, and sending them off. So you can always be useful in a situation like this, no matter how scary the injury looks. Neurovascular injury, we're going to talk a little bit about how to assess neurovascular status of the limbs in a bit. But the basic principles and the golden rules are: you assess the neurovascular status first, then you try and reduce the fracture, even if it's not perfect, but you try and get it roughly in the right position. And then you're going to try and hold it there, so splint it with usually a back slab of some kind, and then reassess the neurovascular status. High energy injuries, always a risk of compartment syndrome, and we're going to talk about compartment syndrome shortly. And then, like I said, it's a multidisciplinary thing. So you're gonna be calling plastics early. So if you're in that major trauma centre, usually plastics are co-located, and they'll come and assess the patient with you. The rules are to kind of just remove gross contaminants only, not you're not going to be pouring saline through it and giving it a thorough wash down in A&E. That all happens up in theatre. You're going to be taking a photograph of it on a clinically approved camera, not on your phones. And you're going to be putting some saline soaked gauze in it, a clear dressing, a back slab, which is what the POP stands for, plaster of Paris, and then again reassess the neurovascular status. They're going to need X-rays after your attempted reduction, and a CT angiogram usually, which is what the plastic guys want to plan their soft tissue reconstruction, usually a free tissue flap. The guidelines I've put at the top of the page here, if you go on to BOA, if you just type in BOA open fractures or open fracture guidelines, the BOA have tons of guidance on all different sorts of trauma scenarios. So lots of guidance to be had there. There's always stuff you can look up, even in A&E. Next slide. So neurovascular injury. So obviously they're gonna die from bleeding before they're going to die of a nerve injury. So it's obviously really important to kind of figure out the arterial injury first, or the bleeding injury first. You can have, bleeding takes kind of different forms. You can either have catastrophic hemorrhage, where you've blown off an arm or a leg and you've got a big arterial bleed, or you've had a significant pelvic injury and you're bleeding internally. So there's internal versus external bleeding. Your bleeding could be arterial versus venous bleeding. And then sometimes you can just have a reduced pulse, where, for example, the fracture may be just compressing or squashing the artery, and so reducing the flow through the limb. And sometimes you can have an absent pulse, which again could still just be the fracture pressing on the compressing the artery, or it could be it's completely severed the artery. Usually the golden rules are you try and reduce the fracture after you've assessed them, and sometimes the pulse will come back after you reduce the fracture. In fact, more often than not it will. Next slide. So this is just a quick slide on catastrophic hemorrhage. This will serve you whether you're in hospital or out and about, and you get asked to help someone who's just been hit by a car or something. But if you see catastrophic hemorrhage, always apply pressure first before you do anything. Tourniquets have had kind of a mixed press, and they sort of fell out of favour a while ago. The military obviously used them quite extensively. Don't worry, this photograph at the bottom was a training exercise. It wasn't actually, and this isn't an actual picture, but scenes like that certainly were commonplace in Iraq. The most A&Es and ambulance crews will have these sorts of tourniquets that you see on the right. It's always important just to kind of make sure, even as an SHO or a foundation doctor, you can point out and say, has the time that it's been applied been marked? If you think about it, in the kind of rush of everything, it's very easy to forget when that tourniquet was put on. And sometimes it's been known that these tourniquets could have been left on too long and then actually cause an ischemic limb. So always worth just keeping an eye on that. We tend to say no longer than 2 hours worth of tourniquet time, and that's pretty much what we stick to in theatre as well. Next slide. So neurovascular injury, again, so we've sort of mentioned whether it's sort of internal or external bleeding, arterial versus venous, whatever it is you're going to do, it's going to crop up in your primary survey. So you've done your airway, you've secured the airway, patient's breathing okay, you've moved on to assessing their circulation. You want to find out whether they're in shock, and I'll give you a quick table on that in the next slide. But most important really is that you assess these big areas where patients can lose loads of blood without you even kind of knowing. So they lose loads of blood in the chest, so with a big pneumothorax, in the abdomen with a big abdominal bleed. Pelvis, you can literally drop your entire intravascular volume into your pelvis. Long bone fractures, so fractured femori, that they will bleed and bleed and bleed. And so it's really important that you get regular observations, get your ECG, get good IV access, and give them a fluid challenge. Usually, if they're an adult, 250 mils of normal saline. We're not so into the colloids anymore. So you want to give them a fluid challenge of 250 mils of saline. And if they're in serious shock and really clapped out, then you need to think about activating a code red, which is a major hemorrhage protocol. And the most important thing really is that the patient gets is that you replace the like with like. So if they've lost blood, you need to replace it with blood. And a code red will basically give you a pack of blood, plasma, fresh frozen plasma, and fibrinogen, and usually in quantities of 1 to 1 to 1, so a ratio of 1 to 1 to 1. So always go for the big orange or grey cannulae in both antecubital fossa if you can. Next slide, please. Here's a quick table which I think probably would be useful for you to have a rough idea about when it comes to finals. Certainly be a reasonable idea if you're kind of on an orthopaedic firm. You don't need to learn the kind of ins and outs of it, but if you look at the top line, this is usually covered in ATLS, Advanced Trauma Life Support, which is a course that kind of teaches people who end up dealing with trauma how to manage things. But there's 4 different classes of hemorrhagic shock. And the way to remember it is a bit like a tennis score. So 0 to 15 is class 1, 15 to 30 class 2, 30 to 40 class 3, and greater than 40 class 4. And that's associated with the percentage of blood loss. You basically just keep an eye on their pulse rate. So less than 100, you're fairly okay with that. Greater than 140, they're in serious shock. And then later on down the line, their renal function starts to deteriorate. They become more confused and more agitated. Beware, obviously, the older patients who are on beta blockers, because you'll often get kind of false readings on their heart rate, etc. Next slide, please. So we're going to cover this slide again a bit later on in the talk, but I'm just going to give you a couple of examples of upper limb and lower limb neurovascular injuries. This is an upper limb injury. So this is what we call a supracondylar. So the condyles are the sort of knobbly bits of the distal humerus. So if you look on the X-ray on the left of your screen, the bone that's coming at the top that obviously looks fractured, pointed to by the yellow arrow, is the humerus and the distal humerus, and that's been fractured and it's extended back. And the problem with it extending back is that it puts the neurovascular structures that sit in the front of the elbow and the antecubital fossa under stretch. So you can imagine they're literally tent over the fractured end of the bone, and so you can imagine there is a risk of nerve and vessel injury. The most common kind of obviously the vessel there is the brachial artery, and the most common nerve to be injured is the anterior interosseous nerve, which is the motor branch of the median nerve, and we're going to talk about how to assess that shortly. This injury happens quite commonly in children, and you will almost certainly be asked to, if you're an orthopaedic firm, you will see these patients come in, particularly in the summer, with them trampolining and on scooters and all the rest of it. Next slide. So how do you assess a vascular injury? Well, it's kind of the same as I sort of alluded to before. You're going to do bedside, laboratory, and special tests. So the bedside test we're going to focus on, which is going to be your history. So you want to find out about how it all happened. You've always got to be, especially when it comes to children, as this is a childhood injury, always be aware of or wary of stories that either don't add up, don't make sense, or are inconsistent with the injury pattern itself, or if they change their story, because that may well be a sign of a non-accidental injury. So always just have that in the back of your mind. When it comes to examination findings, you're going to look, feel, move, or look and feel. You're not going to move this arm because of the risk to neurovascular structures. But you're going to look at the hand, in particular, and the fingers. You're going to look for signs of active bleeding. Often around the elbow, you'll find bruising around the elbow. usually because the fracture may have perforated through brachialis and punctured that, and you often get some puckering around the antecubital fossas. That's always a good sign that there may be a nasty injury to the underlying vessel. Have a look at the fingertips. So are they pale? Is the hand pale itself? Is the hand swollen, or is the forearm swollen? There is a risk of compartment syndrome with these injuries. You're going to feel, so you're going to feel the radial pulse. You're going to feel the capillary refill. Normal is 2 seconds. You're going to press down on the pulp of the finger for about 5 seconds, let go, and then you're expecting the colour to return within 2 seconds. Have a feel for temperature change. So obviously if they have a neurovascular injury or a vessel injury, they're going to have cold fingers, but can be confusing if they've been outside for a long time, for example, and they're just generally cold. So always have a feel of the other side. So God gave us two sides. So as long as they have both their hands, you should always be able to check the bilateral side to see if the pulse is any different or if the temperature change is any different. Special tests. So you could do an Allen's test, which is testing for collateral circulation. You basically occlude the radial artery and then see if the hand remains well perfused or not, so if it remains pink or white or not, and that can tell you whether the ulnar circulation is any good. You can use an oxygen sats probe, and you can again compare different sides to see whether the oxygen sats probe is recording a pulse or blood flow through the fingers, and if you're really worried, you can use a Doppler scan. Or a Doppler ultrasound, sorry, to try and hear the pulse. Next slide. So this is the very kind of basic screening, really, for a neurological injury of the upper limb, which we tend to use in orthopaedics. It's probably not going to help you pass finals. You need to kind of learn your proper peripheral nerve exam. But for A&E and on the wards, post-op with any patients who've had upper limb surgery or upper limb trauma or anything like that, this is pretty much the kind of gold standard sort of screening test that we all tend to use, and it's very easy to remember. You're going to ask the patient to make an OK sign, thumbs up, and fingers crossed. And the OK sign it tests your anterior interosseous nerve, which is the motor branch of the median nerve, and that basically, if you can have a look, if you look at how you form an O, you've got to flex your thumb, so that's flexor pollicis longus, FPL, and you've got to flex your distal interphalangeal joints. You want to get them to do that, and to do that, that's FDP, so flexor digitorum profundus, and that's also controlled by the anterior interosseous nerve. So you want to do an OK sign at that. Thumbs up, and that's going to test your posterior interosseous nerve, which is the motor branch of the radial nerve, and that's going to test your EPL. If you make a thumbs up now and you have a look at the back of your thumb, most people would be able to see a sort of prominent tendon, which is just to the sort of right of the anatomical snuff box, and that's your extensor pollicis longus tendon. That's EPL. Fingers crossed. So there's lots of ways of testing the ulnar nerve, but a really easy one is just to do that. You can also get them to spread their fingers. There's a few other tests besides, but if you can do fingers crossed and even fingers crossed the other side, that's going to test their interosseous muscles. So their palmar and dorsal interossei, which you've got the pad and dab, haven't you? So the palmar, which is adduction, and dab, which is abduction of the fingers. So if you do fingers crossed, it tends to do that. Things spread out does the same thing. Next slide. So that's motor. That's testing the motor aspect of the hand. Another brief screening tool for the sensory aspect is as I've indicated here. So I tend to touch them just in the first dorsal web space. That's your radial nerve. Also happens to be C6. So I'm testing kind of spinal roots as well, as it sort of overlaps. Median nerve is the tip of the index finger. That's purely innervated by the median nerve. And then the ulnar is just the tip of the little finger. So I basically go, can you do an OK, thumbs up, fingers crossed? Can you feel me touching here, here, and here? Does it feel the same or different to the other side? And that really is your screening test for upper limb. It's as simple as that. Next slide. So this is just an example of a neurovascular injury for the lower limb. There's any number of sort of traumatic cases that can cause problems. You can have hip dislocations, you can have fractures, you can have ankle fracture dislocations. I've just chosen one example, which in this case is a knee dislocation. This is a posterior dislocation because the tibia has gone backwards on the femur. Actually, anterior dislocations are more common, but posterior dislocations are more commonly associated with neurovascular injuries. Slightly confusing, but basically, as a posterior dislocation, there is a chance of a neurovascular injury. The vessels affected would be the popliteal artery, which you can see it's under stretch with the dislocation, and the nerves at risk would be the common perineal, or indeed the tibial, or combination of any of those. So we're going to just take you through the neurovascular status and assessing that now. So the next slide. So again, you're going to, your bedside laboratory and special tests, we're going to take a history, find out what happened, very important. You're going to find out about their past medical history, social history, etc. When it comes to examination, look and feel and move if appropriate. So you're going to, again, look for active bleeding. You're going to look to see if there's pallor of the foot, look to see if there's swelling in the leg. These are associated with compartment syndrome. Again, we're going to discuss that in a second. And then you're going to feel for the dorsalis pedis and the posterior tibial pulses. I'm going to sort of show you how to do that in a second. Cap refill, same again. Temperature change, same again. And then the special tests. So the O2 SATS probe can come out again if you want. Dopplers, definitely. But ABPI, so the ankle brachial pressure index. So that literally is you blow up a pressure cuff, a simple blood pressure cuff just above their ankle. You do the same thing again for the regular kind of just above the antecubital fossa, and then you divide the two. And if it's less than 0.8, then they have they may well have a vessel injury. Often with these, you don't get the vessel fully rupturing. You can get what's called an intimal tear, where just the muscle lining within the artery kind of pulls away, and that can cause a blockage or even enough turbulent flow for the blood to clot within the vessel. And so that's why a CT angiogram is often required if you're at all worried with the ABPIs. Next slide. So just very quickly, again, I hope I'm not teaching how to suck eggs, but this is something I kind of struggle with to kind of help locate. So you're going to look at your dorsalis pedis. So if you basically kind of run a finger up from your first web space between your big toe and the next toe along and the second toe, and in that web space, and then you just kind of run your finger along, the pulse will be somewhere there. And usually it's a few centimeters proximal to that. Again, always compare with other sides. Sometimes your patients is just difficult to, it's just difficult to palpate it, but have a feel on the other side, see if it's easier to palpate it on the other side. And sometimes it can give you clues as to where it might be on the side you're looking for. Posterior tibial pulse, so that's going to be behind your medial malleolus. To have a feel, you have a feel now even just behind your the inner aspect of your ankle, your medial malleolus, and your pulse should be sitting just behind it. Next slide. Quick neurological assessment. So, I mean, really, I just get them to wiggle their toes, but if you're going to do it slightly more properly, you're going to ask them to dorsiflex their big toe, which is EHL, and that's controlled by your deep perineal nerve. You're going to get them to evert their foot. You can often do that against resistance, and that's their superficial perineal nerve, which supplies peroneus longus and brevis. And their tibial nerve is what's going to get them to kind of plantarflex their foot. As that's the motor bit, and then the sensory bits on the next slide. So again, you're going back to the dorsal first web space, and that's going to be a deep perineal nerve. And the superficial perineal nerve does just the rest of the dorsum of the foot, essentially. So it's important to test sensation as well. And then the tibial nerve does the plantar aspect of the foot. Next slide. Really, the golden rules with any kind of neurovascular injury or any fracture even is that you assess the patient's neurovascular status. We've just covered how to very quickly assess a patient's upper and lower limb neurovascular status. If you're at all worried and it's kind of related to a fracture or a dislocation, you're going to get some help with your registrar or your SHO, and you're going to look at giving the patient some analgesia, reduce the fracture, splint it with however you like, but usually with a plaster, with a back slab, and then you're going to reassess the patient's neurovascular status, and then usually do another X-ray as well to make sure that you haven't done something awful with the reduction and it's in a worse position than it started. Next slide. Compartment syndrome. So we've mentioned this a few times already. So lots of different definitions, all of them, well, some of them quite confusing, but basically, if you imagine the picture on the right is an awful picture really, but it's just showing that the muscle compartments in every limb are divided into sort of fascial compartments. And the reason for that is that they're all just grouped in sort of similar function. But they also it helps them to move sort of independently of each other. And if you have a significant injury to a limb, then you essentially get bleeding and swelling within the tissue, and that will cut off the blood supply to the local cells within the muscle. And so the definition really is an increase in pressure of an osteofascial compartment. So osseo, bone, fascial, fascia. So it's the fascia that's attached to the bone that encompasses the muscle. And it's an increase in the capillary, in the compartment pressure above the capillary perfusion pressure. So the capillary perfusion pressure is basically the pressure required to get blood into the muscle cells through the capillaries. And if the pressure in the compartment is greater than that, then the cells aren't going to get the blood, they're not going to get oxygenated blood, the cells will become hypoxic, and then they will die and become necrotic. And that is a life-threatening injury, a limb-threatening injury. The other definitions include an absolute compartment pressure greater than 30 millimeters of mercury. It is possible to measure intracompartmental pressure, but really this is a clinical diagnosis, and I'm going to go into that in just a second. Where measuring pressures comes into it is often patients who are on ITU, who are tubed and ventilated and essentially unconscious and can't tell you that they're in pain. And so you can sometimes measure their pressures on the ward with a device. And the last definition is very confusing, but basically if you have an intracompartmental pressure within 30 millimeters of mercury, the diastolic pressure. So if your compartmental pressure is less than, or sort of, less than 30 millimeters within the diastolic pressure, then that's also a diagnosis of compartment syndrome. It's a confusing definition. And if we go to the next slide, I'm just going to tell you now, you can learn it if you want. And when it comes to doing the FRCS exams and stuff, you can. But if you go to the next slide, it's a clinical, it really is a clinical diagnosis. And these are the clinical signs that they sort of tell you on the website. So pain, they're going to complain of pain, they're going to complain of paresthesia, so altered sensation. There may be pallor in the limb, they might not be able to move it, might be paralysis. Pulselessness, incredibly late sign, really late sign. Patients can definitely have pulses present in their limb and still have compartment syndrome. And if we go to the next slide, in my books, that's still not how you clinically diagnose compartment syndrome. And we go to the next slide. The way you diagnose compartment syndrome is with the 5 Ps is pain, 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 pain. It is incredibly painful. And someone told me this when I was at kind of your stage, and I never forgot it. If you just remember that compartment syndrome is incredibly painful and it's a clinical diagnosis, so you suspect they have compartment syndrome, you need to tell your senior that you think they might have it. And that patient must be assessed quickly. So if you go to the next slide, and this is what you're going to see. I mean, probably even worse than this, but you're going to see a patient who is kind of upright in their bed and is screaming the house down. And the nurse will tell you he's had so much morphine, they can't give you any more morphine. He's had paracetamol, he's had all the painkillers going, and it's still painful. You need to think about that. And it can happen, it usually happens with high energy mechanisms, so being hit by a car. It can happen post-operatively with surgery on the lower leg. There are lots of different ways, but if you're presented with this problem, always think compartment syndrome. And compartment syndrome can happen in the lower legs, so around the tibia, but also around the thighs and around the femur. It can also happen in the upper limbs as well. So never forget that compartment syndrome can happen in the upper limbs. It can happen in around your humerus and around your forearm as well. So you can get it anywhere you have a limb, even a foot and a hand. So you can get compartment syndrome anywhere in any limb. Next slide. This is just a quick thing about how to deal with it. So if you get faced with someone who has suspected compartment syndrome, I think one of the biggest problems that sort of foundation doctors have, one of the things that they're so worried about is do you kind of release the back slab or not, and if so, how? And some of you guys just don't know what a back slab is, and that's absolutely fine. It was a while before I did as well, but basically we use back slabs in trauma and often even post-operatively because it's only half of a full plaster of Paris. So normally with a full cast, you're going all the way around the leg. With a back slab, it's just on the back half of the limb. So we start off at the top left of the screen, there's often kind of some sort of crepe-like bandage that they put on at the beginning. Then they dress the leg in wool, and then they basically put this back slab, this half bit of plaster cast material on the back of the leg, and then they will wrap that up in more crepe bandage. And if you're faced with a patient with compartment syndrome, whether it's an upper limb or lower limb, it is okay to basically cut through that back slab and elevate the limb to the level of the heart or just above, and wait half an hour and then reassess. I think really genuinely, if you are suspecting compartment syndrome, don't wait to get through to your registrar to ask them permission. It's okay. You're not going to do the patient loads of harm by just cutting their back slab. And the way you should cut it is instead of cutting it through the hard bit at the back, you want to use a good pair of scissors, and you're going to cut through all of the soft stuff on the front of the leg. So you're going to cut through the crepe bandage, you're going to cut through the wool, you're going to cut through anything until you get down to skin. And you just want to make sure that cast has been released, because that can certainly contribute to the compartment syndrome. Sometimes back slabs go on too tight in theatre and they need to be released. You're not going to do the patient you're going to do the patient more harm if you don't release what we call the circumferential dressings than if you just leave it there. So it's just a quick note to say, don't worry about it. You'll never get told off for doing it. You don't want to take the whole thing off. Just keep it in situ, but make sure you just cut all the way down from the very top to the very bottom. Next slide. And hopefully you wait half an hour with the leg elevated, and then you end up with a happy looking patient. And so you can see that that plaster cast doesn't look like it's very good anymore. I mean, it's sort of doing a job sort of keeping the leg in roughly the right position, but someone's obviously released that plaster cut, that back slab, and the patient's much happier. And sometimes that'll be enough. Sometimes you can prevent the compartment syndrome from developing or progressing just by releasing the dressings. But if not, if you go to the next slide, then unfortunately they're going to need a fasciotomy, which is basically 2 incisions either side of the leg or the arm to release the muscle that's essentially being starved of oxygen because of all that compression. So you're just giving the muscle a chance to breathe, and that's an orthopaedic emergency. Okay, next slide. Septic arthritis. Okay, so these are all really big topics. I don't have all night to kind of go on about it, but basically you're going to do your bedside tests. So you're going to take a good history, find out whether they're unwell or well, whether they've had fevers, night sweats. Those are your big red flags. Past medical history, so whether they have this is kind of important. So whether you want to really clarify whether it's a native joint, i.e. just their own knee or hip joint, or elbow joint, whatever it is, or if it's a prosthetic joint. So if they had a hip or knee replacement. You want to find out things whether they're an intravenous drug user, because they're at high risk of staphylococcal and pneumococcal infections. You're going to look, feel, move. So these are all your bedside tests. So you want to see whether it's red, swollen, is there a sinus, or is there pus coming up from a wound? You want to make sure, you want to have a look at their gait and see, are they able to weight bear or not? In my books, if they're unable to weight bear, that's really highly suspicious of a septic arthritis. You're going to feel, is it warm, is there an effusion, and you're going to move, you're going to try and move the joint. If they can't move their joint, if they have reduced or absent range of movement and they can't weight bear, that's highly suspicious of a septic arthritis. And the other tests you're going to do are your observations, urine dips, your BMs, because especially with diabetics, high risk of septic arthritis, and an ECG in case they need to go to theatre. Next slide. Laboratory, so you're going to, in particular, you want to do your white cell count and CRP, which I didn't include in here, I'm afraid. Blood cultures, very important, particularly if there's spiking temperatures. Special tests, always get an X-ray. You can also, may also help to differentiate between osteomyelitis as well. In children, you often have to get an ultrasound scan, plus or minus an MRI. Joint aspirations, I sort of touched on before as a big pitfall. So often on your kind of competencies, you'll be asked as a foundation doctor to do a joint aspiration. Definitely something you should all do. The knee's the easy one, really. Elbow's reasonably easy too. And that's kind of fair enough in a native joint. So you'd always try and aspirate the joint before giving antibiotics. That's a really important rule. So never just give them antibiotics because you think they have septic arthritis. Always try and get something out of the joint first. And the reason for that is because we want to try and grow a bug in the labs and then help direct antibiotic therapy. But if it's a prosthetic joint, you never, ever do an aspiration in A&E or on the ward of a prosthetic joint. That's something that needs to happen in sterile conditions in theatre. If you go to the next slide. So just as I've said, don't start antibiotics until you've done the aspiration and cultures, and don't aspirate a prosthetic joint in A&E in the ward. Okay, so that's a really important point. Next slide. So septic arthritis, just to clarify, if you're not really sure the difference between a native versus prosthetic joint, so the slide on the left is a native hip joint. That would be a septic arthritis. The X-ray on the right is of a total hip replacement. That would be a prosthetic joint infection, and they are managed differently. Next slide. Same for a knee. So septic arthritis on the left because it's a native joint, and a prosthetic joint infection on the right. So just remember, don't start antibiotics until you've aspirated or you've done blood cultures. And the only kind of exception to that rule is if they're crushingly septic and they're in septic shock, in which case give them the antibiotics. But usually there's time to get an aspiration done before that. Next slide. Okay, necrotizing fasciitis. I realised it was a little bit pushed for time, so I'm going to try and just kind of speed up a bit. But that's a sort of basically the flesh-eating bacteria, which you may or may not have heard of, and it will involve skin, fat, fascia, muscle. This is a life-threatening condition, can cause multi-organ failure. It often presents as a really bad cellulitis, and I often get calls from medical teams and medical wards for patients who have cellulitis, and they say query neck fash. You can see on the picture here that they've obviously started off with a cellulitis, which has been marked in that black sort of ring and pen. And you've got spreading cellulitis there, which is spread beyond that line. Always good when you're marking an area of cellulitis to do a time and date stamp, and that will give you an idea about how quickly it's spread. Next slide. Next slide. And this is why it's such a devastating thing. It can sometimes look quite innocuous, and this is the kind of result. So it's a deadly sort of condition that must be identified quickly. Next slide. So on examination, the patient will be incredibly unwell. They'll have spreading cellulitis, like I said. Other subtle signs. So sometimes they have something called surgical emphysema, where basically you'll palpate the skin, you'll feel the skin, and it will feel like it's crackly, like kind of sort of like snap, crackle, and pop underneath their skin. It's a bizarre feeling, but it's basically because some of the bacteria that cause neck fash are gas-forming bacteria, and so the gas gets trapped underneath the skin. The skin often feels very different. It feels like quite woody and quite hard. And so those are just kind of general signs to look out for. Blood tests, always get an ABG and a lactate with anyone that's sick. And there is a scoring system called the LRINEC score. You're not expected to learn it for finals, but if you think neck fash, if you just type on Google neck fash severity score, it'll come up, and it'll tell you which bloods to do, and based on those bloods, what their chances are of having neck fash. And that's something you could then present to whoever you're referring to. It's a quite useful thing. Initial treatment, you need to get IV access in, big wide bore cannulae, loads of fluids, and call for help. Next slide. Flex sheath infection. Some of you may never have heard of this. I don't think I did until I was doing a plastics SHO job, but plastics and orthopaedics both deal with it. If you go to the next slide. So just a little bit about the anatomy. We all have a sheath, a fibrous sheath that surrounds the flexor tendons in the fingers that allow you to flex your fingers. If you get pus within there, the reason why it's an orthopaedic emergency is that the pus can then track all the way back through your finger into the deep space of your hand. And most common bacteria is a staphylococcal infection, and that can literally just destroy all the soft tissues in your hand, and you'll end up with chronic contractures, and it will forever affect your hand function. So it's a severely, potentially debilitating problem. Just note there on the left-hand side that the finger is sausage shaped. It's much more swollen than the other fingers. And if we go to the next slide, the big 4 signs are called Canaveral signs. You basically end up with a fusiform swelling. Fusiform means sausage, or uniform sausage-shaped swelling. So the finger will look about 2 or 3 times the size of the other ones. Because the flexor sheath is all filled with pus, the finger will start to flex. So the finger will be held in flexion. It'll be very painful to touch. So when you touch it, it'll be very tender. And when you try and extend the finger, it'll be really, really painful. So those are the big sort of signs that you look out for when you're examining the finger. Of course, always assess neurovascular status, take a full history, do the obs, do the bloods, treat it like you would any other sepsis patient. Next slide. Cauda equina syndrome. So this is a big one. We get referrals for cauda equina all the time, and it's basically caused by compression of the cauda equina, the horse's tail, and their nerve roots, and usually it's caused by a slipped disc, but it can also be caused by fracture, tumour, and various other things. Delays in treatment can result in permanent neurologic dysfunction, so incontinence, either of bladder or feces, or paralysis. Next slide. So the red flags, and this is kind of taken straight off of the website from the neurosurgeons. Sorry, I just had to let my cat out. So basically, any patient presenting with back pain and unilateral or bilateral sciatica, and this is usually an acute history. Any patient with motor weakness in the legs, saddle anesthesia, so that's in your saddle area, in your groin and buttocks, loss of anal tone, and loss of urinary control. So normally they may well have just urinary incontinence, but more often than not, they have retention and then overflow incontinence. And it's a dynamic thing. So they may just present with one of these symptoms, they may present with all of them, and it can sometimes evolve very quickly. And so we often get referrals from GPs in particular where patients will present with 1 or 2 of these symptoms only, and we will have to see them to rule out cauda equina syndrome. Next slide. So you're going to do a full history, you're going to do a full neurological exam. I've put in here brackets, Asia chart. That will give you a PDF that you can print out, and it will give you a very structured way of doing a neurological exam. And the reason why it's so good is because it's sort of approved and by various societies. It's a very objective neurological assessment, and you can repeat that same test hours later to see if the neurology is evolving or not. You can do a bladder scan, plus or minus catheter if they seem to be in retention. You're going to do standard laboratory tests because they may need to go theatre, and really the gold standard is an MRI scan to see what's going on, whether there's compression of the cauda equina. I've put here in the warning box, always do a PR exam. And I was always told if you don't put your finger in it, you'll put your foot in it, which sounds really gross, but basically, I always get asked, do I need to do a PR exam? The answer is always yes. And the anal tone, please, is never reduced or weak or whatever. It's either present or it's not. It's a very binary thing. Either you can feel a squeeze on your finger, no matter how subtle, or you can't. It's really that simple. Because if you say, oh well, it's reduced, well then that's saying that you've examined their rectum before, and you're making a comparison, which I hope many of you, I hope you wouldn't, but I hope that makes sense. Next slide. And here's an MRI scan, just kind of showing a Cauda equina with a big slit disc pointed with all the arrows that's compressing on the disc, and that's going to need to go to theatre urgently and have it decompressed probably that night. And so if you have a patient with suspected Cauda equina, tell your registrar about it. They should be getting MRIs 24/7. That should be available. That is now national guidance. It doesn't happen everywhere, but it should, and there should be no delay in surgical decompression. Next slide. We're almost there. So number 8, so nasty fracture dislocations. So this is a nasty fracture dislocation of the ankle. You will see them in all different areas of the body. If you have a very quick feel on your medial malleolus, the inside of your ankle, this X-ray's showing just how close the bone gets to the skin. And so the most important thing is that you have to do a neurovascular assessment, and you need to reduce the ankle, splint it, and then reassess. So if you go to the next slide. So like I said, the golden rules: assess neurovascular status in the way that I've told you already. Reduce and splint the fractures, something you could do with your registrar. Reassess the neurovascular status, assess for compartment syndrome, which we already discussed, and X-ray the limb in plaster. Next slide. Supracondylar fractures. So thankfully we've already touched on this a bit. So very common in children. The one difference to this rule of assess neurovascular status, reduce the limb and splint, is that in these children you're not going to attempt reduction, not in A&E. An injury like this will need to go to theatre more often than not, and by kind of faffing around in A&E, there's a high risk you could cause neurovascular injury. It's also very distressing for the child and for the family. So you tend to just put them in a back slab in situ. Next slide. So as I've said here, you're going to put just a back slab on, usually above elbow, to stop the arm from moving. And just by splinting the arm, that's going to give them a lot of pain relief. You're going to give them intranasal diamorph, which again, good pain relief, but you're not going to try and pull the limb and try and reduce it. This is one of the few cases where you really don't want to move it. You're just going to splint it in situ, and always X-ray the limb. Next slide. So hip fractures, I'm going to have to try and whiz through this because I'm conscious of that we are running out of time a bit. And if the committee just let me know how much time I've got left, that'd be good. So hip fractures, incredibly common reason for orthopaedic admission. If you're working on orthopaedics, if you're working A&E, if you're doing geriatrics or orthogeries, you will need to know how to manage these patients inside and out. So you should, as a final year medical student and as a junior doctor, know a bit of anatomy around the hip and hip fractures and how decisions are made. One of the reasons it's really important is that traditionally hip fracture care has historically been terrible, and patients, these elderly, very frail patients, have a high risk of mortality and morbidity. And if they're not treated properly, they will just die, and are very difficult to nurse as well. So hip fracture care has been improved by introducing a financial incentive to make sure that hospitals that deal with hip fractures do it better, and you're a big part of that. So as a SHO or a doctor on the firm, you will be very closely involved with that. And if you don't fill out the various performers that are in place, the trust loses money for not providing sufficiently good hip fracture care. Next slide. So you will get this, you will almost certainly get this in finals. You'll definitely get it if you're an orthopaedic firm. The most predominant blood supply to the femoral head is the medial circumflex femoral artery, which comes off your profunda femoral artery. And I'm pointing to that in the big red arrow that you see on the right side of the page. That's the predominant supply. And the reason that I'm going into this very briefly is that blood supply then joins the lateral circumflex femoral, which has a slightly less dominant supply, and it forms these what we call retinacular vessels, which so the anastomosis between the medial circumflex and the lateral circumflex I've highlighted in blue, and that's just, you can see that circling around the base of the neck of the femur. And then the retinacular vessels are the vessels that go up into the head, and that's indicated by the green arrow, the big green arrow. And it's a form of what we call retrograde blood supply. So it's going from distal, so from the bottom all the way to the top, so to the top of the femoral head. So it's a retrograde blood supply. And if we go to the next slide, it also happens to be, so I've basically marked in that green dotted line where this anastomosis is between the two circumflex vessels. And it also happens to be exactly where the capsule, so the synovial joint capsule that covers the hip, it's also where that joins as well. And the reason why that's important is we have to make a distinction between whether the fracture is intracapsular, so above the green line, or extracapsular, so below the green line. And you'll hear lots of different terms used for different intracapsular fractures and different extracapsular fractures, which we'll talk about in a second. But you really, at finals level, you just want to make a distinction. Is it intracapsular or is it extracapsular? And the reason that's important is because if it's an intracapsular fracture, so above the green line, there's a chance that you've ruptured those retinacular vessels, the ones that are coming up, providing that blood supply to the femoral head. And there's a chance you've basically ruptured them. And if you've ruptured them, then the femoral head will lose its blood supply, and the bone will literally just disintegrate. And so the patient won't be able to walk properly if that happens. So if you go to the next slide. So again, this is an X-ray, which you'll be, if you're in an X-ray meeting, you'll get asked the same thing. Is this fracture intracapsular or extracapsular? So there's the green line. Everything above it is intracapsular. A fracture below it is extracapsular. Next slide. So the words that you'll hear banded around are things like subcapital. So if you imagine you've got the femoral head, which is the ball of the ball and socket joint. Capital means head, capitis. And so subcapital means just below the head. Cervical means the neck of the femur, and basicervical means just at the bottom. So just approaching, just above that green line. But all of those are intracapsular fractures, and so they're all basically managed the same, by and large. The extracapsular fractures are all below that line, and you'll hear words like intertrochanteric. So you've got the greater trochanter, which is the big lumpy thing on the side, and the lesser trochanter, which is the smaller lumpy thing on the medial aspect of the femur. If you get a fracture between those lines, essentially just below the green line, that's an intertrochanteric fracture. If you get a fracture below the lesser trochanter, the small bump, that's a subtrochanteric fracture. But they're both extracapsular fractures. And so if you go to the next slide, I've just summarized. So intracapsular fractures above the green line. I'm hoping I've sort of emphasized my point here. Above the green line, intracapsular fracture, risk to the head. So think about risk to the head, replace. So they're going to have a hemiarthroplasty, which is half a hip replacement. We're just replacing the ball of the ball and socket joint, or a total hip replacement, whether you're going to be replacing both the ball and the socket. And we'll talk about why we do that in a second. If it's an extracapsular fracture, so below that green line, there's no risk to the blood supply, so no risk to the head. So you're going to fix the fracture, because ultimately their own anatomy, their own bone, which is going to survive because the blood supply hasn't been interrupted, is going to be better than any implant we give them. So they're going to get a dynamic hip screw or an intramedullary nail. We're going to talk about that in a sec. Next slide. So DHS, so you can see the picture on the left is where they fractured. That's an intertrochanteric fracture. And so they've been fixed with a dynamic hip screw. I don't have time right now to go through how dynamic hip screws work, but it's an extracapsular fracture. There's no risk to the head. They're going to be fixed. And we're fixing it with this big screw and a plate. You go to the next slide. And similarly, so this is a fracture which is which would have been below that line. It's a subtrochanteric fracture. This is actually a pathologic fracture, so it's actually a metastatic deposit in the femur which has caused it to fracture. This patient is going to be fixed because the blood supply to the head is still fine, and they're going to be fixed with an intramedullary nail, which is a big rod. Next slide. So with hemiarthroplasties, so these are fractures that occur, intracapsular fractures, and so threaten to the blood supply. The way that we differentiate between them on X-ray and why we give them to different patients is because the patients who are usually older, so usually kind of above the sort of 80 mark, or if they have an AMT of less, so an acute mental test score of less than 9, or if they are unable to, or if they have to mobilize with more than one stick, then usually they're not going to be fit enough for a total hip replacement, because total hip replacement involves replacing both the ball and the socket, which is a much bigger procedure. There's a bigger risk of dislocation, there's a bigger risk of blood loss during surgery. So the patients who are slightly less fit, more comorbid, are going to get hemiarthroplasties. The patients who are more fit are going to get total hip replacements. So if you go to the next slide. So total hip replacement is when we replace the ball and the socket of the joint. We usually use them for just osteoarthritis of the hip or other conditions, sort of elective conditions, but there is a role for them in hip fracture surgery. And it usually are the patients that are kind of, late 60s, early 70s. They'll tell you they have very few comorbidities. They walk the dogs a few miles every day. They have an AMT, an acute mental test score of greater than 9, and they mobilize with, at worst, just one stick. And these are the patients who are probably going to be fit enough for a total hip replacement. And like I said, we make that distinction because patients with hip fracture patients with total hip replacements are at a greater risk of dislocation. So when the ball comes out the socket, they're at greater risk of fractures around the implant. There's more blood loss. It's a much bigger surgery, so you have to be fit enough to tolerate it. And so you're only going to really choose the group of patients who are going to be able to survive the operation and make the most of the implant they're given. You go to the next slide. And just to clarify, those decisions won't be made by you, they'll be made by the registrar and consultant ultimately. And it won't be your job to consent the patients, but you should just be aware, you should be thinking kind of roughly maybe which way these patients are going to go. How to optimize a patient preoperatively. These are good general rules, but in particular for hip fracture patients. So you want to clarify nil by mal status. So are they going to be on a list tomorrow, or are they going to need further optimization before their surgery? What further investigations do you need? So if it's a patient who's had a pathological hip fracture, so a metastatic deposit, are they going to need CT scanning of that area and staging CT scans of their chest, abdo, pelvis? What fluid resuscitation are they going to need? Think about the medications they're on. So are they on warfarin? Does that need reversing? Do they need vitamin K? Are they on a DOAC? Do we need to wait 24, 48 hours before they're safe to have surgery? Are they on anti-inflammatories, which is going to put them at greater risk of infection? Are they on antibiotics, or do they need antibiotics for a chest or urine infection? Often this is the case with patients coming from nursing homes. Make sure you encourage your registrar to mark and consent the patient and add them to the list. You should assess their neurovascular status. It's pretty rare with hip fractures that you get a problem with neurovascular obs, but it's always worth assessing. Elderly patients often have quite calcified vessels, and so you never know. Sometimes they can be ruptured even with small low energy mechanisms. Think about whether they need an anaesthetic review preoperatively, and they should all get an orthogeria review. I've put in the big yellow warning box, best practice tariffs. This may be something you've never heard of, but basically this is the incentive, the financial incentive to deliver that really good care. And usually that means that every hip fracture patient should be clerked examined, and all the investigations put onto one hip fracture performer. So it's usually a booklet that each trust will have their own version of it, but usually there's a booklet which will basically take you through how to clerk in a hip fracture patient and do it properly. You need to get an orthogeriatrician to review them. Doing a mini mental score is incredibly important. It gives, for a number of reasons, first of all, gives you an idea about whether they're going to be able to consent for their procedure or not, and can start giving you a clue as to whether the patient may or may not have capacity. And also patients with hip fractures at high risk of delirium, and so it's often good to have a baseline of their mini mental state or their mental state preoperatively. Make sure the patient has analgesia, and in A&E that's the form of a fascial iliaca block. If you're interested, you can always find someone to teach you how to do them. It's a great thing to be able to learn how to do, great skill. Give them analgesia, but not too much. And then IV access, make sure they have bloods, ECGs, chest x-rays, and any additional imaging. And this is essential for every hip fracture patient that comes in through the door. Next slide. I promise you we don't have that many more to go. We are almost done. Post-op hip care. So again, it will be there for you in the hip fracture performer, including the post-op course. Have a look at the op note, and that's a good top tip really for any surgical firm. Have a look at what they've done. Usually the surgeons will write and tell people what they've done, and if you're not sure, speak to them and find out, did the surgery go okay? Did they lose a lot of blood? Were there any respiratory problems during the case? How are they doing? Because you're probably going to be the ones looking after them on the ward. If they're not requiring high level care, so an HTU or ITU setting, it's going to be you looking after them, and you want to get as much information as you can to do the best job you can in looking after them. Have a think to yourself when you assess the patient: is this patient really suitable for the ward, or should they be in a higher care facility? So should they be in HTU or ITU? Sometimes patients will end up on the ward inappropriately, and it's always worth challenging that, even at your kind of junior stage. Think about the patient's fluid status. Do they need resuscitating? Have a look at their HB post-op. Sometimes, more often than not, you can get away with doing iron supplementation for if they've lost just a small amount of blood. But if they've lost lots of blood and they're symptomatically anemic, so an HB less than usually 8 or 7, depending on trust guidelines, then think about transfusing them. Make sure they've had post-op bloods. Consider their post-op medication. So basically all hip fracture patients should be on a form of DVT prophylaxis or VT thromboprophylaxis. So make sure that that's written up, and if there's a contraindication for that, make sure that's been properly filled out on the drug chart. Make sure they have good analgesia on board, but not too much. Some of these old patients are very opioid sensitive. Usually they'll have a dose or so of antibiotics post-operative as well. Do neurovascular obs, particularly the ones who've had hemiarthroplasties and total hip replacements. There is always a danger of injury to the sciatic nerve, and so they will have a foot drop. So it's important to assess that. Make sure they've had an orthogery review. Outreach, if you're concerned, always escalate, and all patients should be mobilizing day of or day one post-operatively, unless you've been told by the operating surgeon not to. Patients who've had hemiarthroplasty or a total hip replacement will need post-operative x-rays, and that's not so the surgeon can admire their handiwork. It's really to make sure that there hasn't been a intraoperative fracture, sometimes which is a risk, and also to make sure that there's no dislocation as well. So sometimes the hemiarthroplasties and totals can dislocate before they even got back to the ward. It's not usually required. X-rays aren't usually required for DHSs or IM nails because the X-rays were done in theatre. Next slide. Weight-bearing status. I mentioned this just earlier on, but as far as hip fracture patients are concerned, you should just take it as read that every hip fracture patient should be full weight bearing the day of or day one post-operatively. Those are national guidelines, unless there is a reason that the consultant operating surgeon has said otherwise. And if you're not sure, just talk to the registrar or consultant who's done the case. Next slide. Oh, that's it. We're done. Good. Sorry that went slightly over. Sorry about that, guys.
No, that's absolutely fine. Thank you so much, James. It was really good. We do have a couple of questions if you have time.
Of course, yeah, absolutely.
So the first one is, if there is a clear fracture, do you need to x-ray before reducing, or can you just reduce and then x-ray after?
Yeah, so I think good question. Normally, fractures will be referred to you by A&E, so either A&E minors or majors, and usually they will have seen the patient, examined them, and done an X-ray. And when you get the referral, the referral will come with an X-ray. And if the referral doesn't come with an X-ray, and they just say, "I'm suspecting a fracture," without trying to sound awful, like I'm the awful orthopaedic mean registrar, I would actually not see the patient until they've had an X-ray. So always just get an X-ray first, confirm whether there's a fracture or not, and then tell them to make the referral again once they've had the X-ray. And then once you've reduced it, X-ray again. So if you've done anything to a fracture, if you've manipulated it, reduced it, put in a slab, always re-X-ray.
Great. And also, just while I'm here, guys, please remember to do the feedback. It's really useful for us to know what you liked and what you thought could be better. It will take 2 minutes, so please remember to do that. Next question is, how much can we expect as F1s to be involved in assisting in theatres, especially at major trauma centres?
I'm really pleased someone's asked that, because I kind of figured I wouldn't have time to talk about it. I think whether you're interested in surgery or not, so genuinely, if you have no interest in surgery whatsoever and you just want to do medicine or GP or something, anything else, I would really say, like, everyone should try and get themselves to theatre at least once. And like I said, I think the thing that SHOs really struggle with is that there's a big disconnect between what happens in theatres and then what happens on the wards. And often the SHOs on the wards feel quite isolated. They also aren't really sure what happens in theatre. So they just get these like really sick patients that come back from theatre, and they're just like, I've got no idea what's happened, and I don't really know like how I should be looking after them. If you express an interest, or even if you're not particularly interested, but you just want to kind of find out a bit more about what's happened to your patients, they will welcome you with open arms. And I think what I used to do was I would, on days where I was quite keen to go to theatre, and it is difficult to get all your jobs done, I would come in maybe a bit early, and I would try and, or I would make sure my TTAs were done the day before, make sure the bloods and X-rays were ordered for that day, and then I could come in and say to my fellow kind of SHOs or F1s, I'd say, look, I'm kind of keen to go to theatre today. I've done as many jobs as I can. Would someone mind holding my bleep for just the morning, for me to go to theatre, and I'll come back in the afternoon and pick it up off you. And I think that's a reasonable thing to do. And whether you're interested in surgery or not, you will be allowed to. The more you go to theatre, the more you'll get to do. But certainly suture practice, basic wound closure, that sort of thing. And if you're on a firm with me in Bristol or in the surrounding hospitals, I usually get my F2s to do a DHS by the time they're finished on the firm. So that's the kind of bar I set for the SHOs who work for me. So there's nothing stopping you from doing that. But I think even if you're not interested, it's always good to see what happens to the patients and find out. I think it optimizes their care on the ward. So sorry, that's a very long-winded answer, but I hope I've answered your question.
No, that's good. Thank you. Just because of the time, I just wanted to say one comment which we've had through, which I thought you'd quite like to hear, but which is just, your teaching is so concise, engaging and comprehensive. Thank you so much for the webinar. Please do more teaching sessions. It's been so great, and thank you so much for coming on. It's been a very, very useful lecture. And just for everyone else, please remember to do the feedback. It's really, really useful. We hope you've all enjoyed it. And we'll see you tomorrow if you want to for a PEDS lecture, which will be PEDS surgery tomorrow night.
Okay, one very quick thing, sorry. For anyone kind of just along that vein, like orthopedics really isn't just a man's game, and so anyone can do it. You know, whether you're tiny or a really big, you know, sport playing person, like it doesn't matter. We've, you know, orthopedics nowadays is designed so that anyone can do it, and some of the best consultants I've worked for are women, and have been absolute role models for me. So we have the British Orthopaedic Training Association, which has a medical student rep, and so if you're interested in getting involved, please get in touch. We need more women in the specialty, and we need more diversity in the specialty, because that, I think, adds a lot to it, and makes the specialty all better for it.
Yeah. I really value that you've added that in. That's very nice of you. Thank you. Okay, well,
all right.
Thanks very much, guys. I think we will.
No worries. Thanks for having me.
Thank you again, James.
All the best. No worries. Bye now.